Afternoon. Welcome to this webinar on a Saturday afternoon, a sunny one indeed. Hi, my name is Ronald Lee. I'm a cardiologist practicing at NUH. I'm the chair of this webinar, and together with me is Dr. Edgar Tay, a cardiologist in private practice. And Dr. Tay will be the co-chair of this webinar. Thank you once again for joining us today. This webinar is jointly organized by Singapore Cardiac Society and also the ACC Singapore chapter, and is generally supported by V4 Pharma. Okay. And today's webinar's topic is iron deficiency and heart. In the next 1 hour or so, we have 4 presentations. Each will last for 15 minutes. And the Q&A will be placed at the end of the webinar. And without further ado, can I invite the first speaker, Dr. Bernard Koch. Dr. Koch is a nationally and internationally well known for his expertise in heart failure, and is now practicing at the Farrer Park Hospital. Thank you, Dr. Koch.
Thank you, Ronald, and good afternoon, everyone. I'd like to thank the Society as well as the chapter for the invitation for me to speak. Let me start with sharing my slides. I hope it is up. If it's not up, please do let me know. Okay, so the first talk for the day is to talk about iron deficiency and heart failure. What's the big deal about it, how to diagnose and how to treat. I guess the story, that's my disclosure. I have no relevant disclosures pertaining to today's presentation. And you talk about iron deficiency has to start with anemia. And in both registries and as well as clinical trials, the prevalence for anemia in heart failure patients has been estimated to be as low as 4% and as high as 61%. And we know that any heart failure patient with concomitant anemia has worse clinical outcomes. The patient will experience more symptoms, there is reduced exercise tolerance, more likely to require frequent hospitalization, and survival is also impacted. So in other words, anemia itself is an independent predictor of poor outcomes. And what are the common causes of anemia in heart failure? Well, pure nutritional iron deficiency actually is a minority. Most of the time, the anemia in heart failure is deemed to be that of anemia due to chronic disease with a combination, one and or both in terms of iron deficiency or defective, inadequate erythropoietin production. Now, early studies, interventional studies with erythropoietin to treat anemia in heart failure patients have been rather disappointing. Although the very first stamina HEF study showed that there was a reduction in hospitalization, no effect on mortality improvement was seen. And then in another study, HF, there was no benefit at all. And in fact, it raised the alarm of more thromboembolic events. So this concern was particularly in renal failure patients. So the use of erythropoietin to treat anemia in heart failure has largely been abandoned. Moving back to iron deficiency and in heart failure. Now we know that if there is iron deficiency, the body will produce less hemoglobin. With less hemoglobin or anemia, there will be reduced oxygen delivery. But there actually is a double whammy in heart failure because iron deficiency itself leads to defective oxygen utilization at the cellular level. There is less aerobic enzymatic activity, less ATP production, and therefore less oxygen utilization. So there is both less reduced oxygen delivery as well as reduced oxygen utilization. Therefore, the patient's effort or exercise tolerance will be impaired. So looking at it simply in this graphical pictorial form, iron deficiency in heart failure. Now, independent of anemia, regardless of whether the patient has anemia or not, as long as there is iron deficiency, it's been shown to reduce exercise capacity. There is obviously then a poorer quality of life, more hospitalization, and increased all-cause mortality. Naturally, with higher utilization of healthcare resources, medical costs will also be higher. So anemia in most of the heart failure guidelines, international heart failure guidelines, it's been quite routine that to assess a patient with congestive heart failure, we also screen for anemia. And if there is anemia, we always screen for iron deficiency, and it becomes natural to correct the iron deficiency using whatever form we can. As far back as 10 years ago, the European guidelines already listed ferritin as a routine parameter to check. Just like we check hemoglobin, we check platelet count, we check the thyroid function, we check kidney function. We should always be checking routinely for ferritin in our heart failure patients. Now, one of the earliest study using ferric carboxymaltose in iron deficiency in heart failure patient is the FAIR-HF study. And here I have highlighted one of the inclusion criteria, which is the definition for iron deficiency. This definition is almost uniformly used across most of the studies that have been done using intravenous ferric carboxymaltose. The patients that were enrolled were heart failure patients, symptomatic, EF less than 40 or 45%. Hemoglobin is between 9.5 to 13.5, so not necessarily anemic, but certainly iron deficient, either ferritin less than 100 microgram, or if the ferritin is between 100 to 300, then the transferrin saturation is less than 20%. So these patients were obviously, there's a double-blind study, and they were treated with ferric carboxymaltose. So the results were obviously positive, but the outcomes were all subjective outcomes. Patients' own global assessment got better. Patients' NYHA functional class improved. 6-minute walk test became longer, and the quality of life health scores also improved. So these were soft endpoints. So the conclusion of this, one of these early study was that in iron deficient heart failure patients, regardless of whether they are anemic or not, giving them ferric carboxymaltose improved symptoms, improved physical performance, improved quality of life, and it was safe and tolerable. There was another study, the CONFIRM-HF, and that's at the bottom, which only measured the 6-minute walk test. So similarly, by giving such iron deficient heart failure patients IV ferric carboxymaltose, their 6-minute walk distances were on average about 20 to 30% longer. Then there was yet another EFFECT-HF study, which looked at VO2 max. Almost similar patient enrollment, symptomatic heart failure, EF less than 45%, identical definition for iron deficiency, but this study enrolled patients with a hemoglobin up to 15 grams. So after treatment with carboxymaltose, these patients had improvement in their oxygen utility measured objectively. So therefore, this led to the 2016 European guidelines, which revision, which have this specific recommendation for intravenous ferric carboxymaltose to be given to patients with heart failure and iron deficiency as defined in those earlier studies. The class of recommendation was only 2A because the outcomes were soft outcomes and not hard clinical endpoints. But the level of evidence was A because there were multiple trials all giving the same results. The following year, the Americans also updated their heart failure guidelines to essentially the same thing, that patients with symptomatic heart failure plus iron deficiency, they should receive intravenous iron replacement. And this was obviously prompted mainly by the CONFIRM-HF trial result. Another point to note is that in the same update, they specifically mentioned that in anemia, we should not be treating anemia in heart failure patients with erythropoietin, because there is actually no evidence that there is of any therapeutic benefit. The same year, the Canadians also updated their guidelines to fairly similar to the American ones. So number one, in anemia, do not use erythropoietin. Number two, in iron deficiency, use intravenous iron. Now, here in this table, I've listed the interventional trials of iron in heart failure. Those on top are the ones that I talked about: FAIR-HF, CONFIRM-HF, and EFFECT-HF. Why? Because they were all intravenous ferric carboxymaltose. The obvious reason is because of the presence of our sponsor. But actually, the real reason, if you look at the studies below, the ferric HF and iron HF using IV iron sucrose, the patient enrollments were very small. The patient studies were only 35 or 18 in both. Although the effect was fairly similar, it showed that there was improvement in exercise capacity and patient symptoms. The iron out HF study, which used oral polysaccharide iron, was a negative study. Therefore, we should focus our attention to those larger studies that have enrolled hundreds of patients. For example, in FAIR-HF, there was 400 over. In CONFIRM-HF, we had 304 patients. In EFFECT-HF, there was 172. So those intravenous iron carboxymaltose studies had larger patient enrollment. And the effect up to then was quite consistent. Patients had all feel better. If you look at the primary endpoints at the bottom of the table, they subjectively improve. Then in CONFIRM-HF was improvement in 6-minute walk test. In EFFECT-HF was the measured oxygen, maximum oxygen consumption or utility measured by VO2 max improved. And some of these improvements were as early as from week 4 from the replacement of iron. But what I think would excite us most is the fact that there is finally an outcome study using IV ferric carboxymaltose, and that's the AFFIRM-HF study that was published just 2 years ago in the Lancet. So the patient enrolled again was similar to the earlier ones, symptomatic heart failure patients with iron deficiency that were, let me move back to the previous slide, patients with iron deficiency with the same definition. So the same criteria were used, which makes it easy for us to compare against all the studies. But of course, the mode, how, and the dose of intravenous iron that were given was slightly different in the different studies. I go straight to the result of the AFFIRM-HF study, and the primary endpoint was a composite of total heart failure hospitalization and or CV death. And this is where this study for the first time showed that intravenous iron finally can reduce the heart endpoint for heart failure patients with iron deficiency. But bearing in mind that this is a composite endpoint, there is this urge to dissect and split the two composite events. So if you just look at the effect on total heart failure hospitalization, there was a significant, statistically significant benefit when intravenous iron was used. However, if you look at cardiovascular death, there was no difference. So therefore, we know that giving IV iron in heart failure patients with iron deficiency, at the end of the day, is not going to make them live longer, but it reduces their risk of heart failure hospitalization. So the conclusions here are many. Basically, I think what we want to stress is that if we remember to use intravenous iron for such heart failure patients, we are likely to reduce their risk of getting hospitalization, the need for increased healthcare resources, although they may not live longer. So a very easy way of looking at it is the earlier studies, FAIR, CONFIRM, and EFFECT HF, improve exercise capacity and improve QOL. It makes heart failure patients feel better. But AFFIRM AHF tells us that we can keep them out of the hospital. And if they have been hospitalized before, we can help reduce their chance of rehospitalization. So with that publication in 2020, ESC, European Society of Cardiology, in 2021 have updated their guidelines. And what's on the left is nothing new. We use ferric carboxymaltose for symptomatic patients to alleviate symptoms, improve exercise capacity, and improve quality of life. But the AFFIRM AHF now tells us we can use ferric carboxymaltose in patients who are hospitalized for heart failure. We can start the treatment and we will improve their symptoms and reduce their hospitalization. Similarly, even if the patient had already been discharged and we noted the iron deficiency later on, it is still useful to replace the iron with intravenous ferric carboxymaltose to reduce future hospitalization. So this is another way of looking at the same guidelines. If you look at in the table, the second row and the third row are essentially the same thing. You give intravenous iron supplementation, but the objective and the class of recommendation and level of evidence is slightly different. If we are talking about improving symptom, the class of recommendation is 2A, level of evidence is higher, is A. But if we talk about using IV iron to reduce hospitalization, the level of evidence is only B because there is only one randomized trial. But nonetheless, I think as a practicing clinician, it's easy to just remember that give IV iron in iron deficiency plus heart failure to make the patient feel better. So the latest guideline is that of the American one. And in terms of the recommendations for anemia on iron deficiency, no change from the European one. First one is that in first one is that we give IV iron to improve function. Second is that in anemia patients, do not use erythropoietin. It does not improve morbidity, nor does it improve the mortality. So this is my final slide. Just a few take-home messages. In all heart failure patients, check the serum ferritin for the very first time, as you would check their blood counts and kidney function. Serum ferritin as well as the transferrin saturation. And to diagnose iron deficiency, use the following criteria. As long as the serum ferritin is less than 100 microgram, that's iron deficiency. If the ferritin is between 100 to 300, and if the transferrin saturation is less than 20%, that is also iron deficiency, and that means time to treat. And the evidence points to treatment with intravenous ferric carboxymaltose because it is the most well-proven in terms of the number of trials, number of patients enrolled, and the only study, the only product with the outcome trial that has shown a positive effect. Thank you very much.
Thank you, Dr. Kok, for the very informative presentation and yet very practical for clinicians. I know that we initially planned to put the Q&A at the end of the webinar, but perhaps if Dr. Kok doesn't mind, we can quickly answer a few questions first. Dr. Kok, are you able to see the question?
Sorry?
Are you able to see the question? Can you see the question? The Q&A.
Okay, let me. Yeah, okay.
Yeah. The first question is for those with New York Heart Association functional class 1 and not yet anemic, is oral iron effective?
I think the simple answer to that is that group has not been studied, but if you look at it, all the trials have studied symptomatic. That means class 2, class 3, class 4, not class 1. And oral iron has been shown to be ineffective.
Great. The next question will be, what's your thought on other?
Okay. Yes, I see that. So the question is, if ferric carboxymaltose is not available to you, then I guess you can still rely on IV iron sucrose, which had the smaller studies done. And then I guess you will document that the serum ferritin subsequently normalizes. Okay, let me see. Oops. If the hemoglobin is normal, should we still send the ferritin? Yes, that's what the guidelines tell us, and that's what the studies tell us, that regardless of whether the patient is anemic, iron deficiency itself is bad for heart failure. You may have missed my one of my early slides in which iron deficiency has a double whammy. Iron deficiency leads to lower hemoglobin, but iron deficiency also leads to impaired cellular metabolism in terms of oxygen utilization. So your myocytes is not as functioning as effectively as it should. Yeah.
Wow, it's very exciting. Dr. Kong, we have actually keep on having questions coming. Do you think
some of these questions we could keep till at the end. Yeah.
Yeah, if you don't mind, thank you so much. Appreciate that. Okay. Thank you, Dr. Kong, again. Let me introduce the second speaker, Dr. Quek. Dr. Quek is a nephrologist practicing at the Singapore General Hospitals, and his presentation today is on iron deficiency in patients with chronic kidney disease. Dr. Quek, please.
Hi, thanks for the invitations. Can you all hear me?
Yeah, here.
Okay.
Thank you.
So thank you for the invitation. My talk today is on the current opinion and approach to iron deficiency in chronic kidney disease. Okay, so this is briefly my outline of my talk, and I shall move straight on to firstly the definitions of anemia. In the renal or CKD realm, we still use the WHO definitions of a male less than 13 and a female less than 12 as the hemoglobin cut off. However, as the talk progresses on, you realize that we starting to use another level which is less than 10, and the reason will be explained a bit later on. So in terms of prevalence of anemia in CKD, firstly, we know that as the stages of CKD progresses on, of course, the percentage prevalence increases, and whether you use less than 12 or use less than 10. In locally, we do use, there is a small study that looks at the local populations, and again, using a hemoglobin of less than 10, we can see that even at stage 1 and 2 CKD, there's already almost 20% of the patient having anemia. And in the later stage of 3 to 5, there is almost 38%. So it's a very significant number of anemia population we're talking about in the CKD population. We also know that the pathophysiology of anemia, when we talk about red blood cells maturation from the stem cells, the precursor to progenitals, and then finally to the mature red blood cells, we do require the erythropoietin, and we also require the iron. And the iron is actually especially important because it acts right at the progenitor stage where the red blood cells is being maturing into the mature cells, and that is the last part of the maturing process. When we talk about anemia in CKD, apart from the decrease in the erythropoietin productions from the kidney as the kidney function decline, there are a few other factors we are considering. So one of them is actually the hepcidin excess. So hepcidin is this substrate in our body that in a pro-inflammatory stage actually affects a few things, and it especially affects the iron, how the iron is absorbed and how the iron is metabolized in our body. And so it actually prevents and reduces the absorptions of iron from the guts into our body, and it also prevents the deployment of the iron from the macrophages on the liver to the bone marrows for the production. So hepcidin excess is a problem and is always elevated and stimulated in an inflammatory state. And in the CKD population, all our patients are in an inflammatory state, and this is a problem. And the next problem we have is from the hypoxia-inducible factor sensing, oxygen sensing pathway. This is actually a transcription factors which actually facilitate oxygen delivery and the cellular adaptations to hypoxia. And when in a normal oxygen state of things, the proline hydroxylase protein does quickly degrades this HIF such that it doesn't stimulate. So, but in a hypoxia state, the converse happened where the hydroxylation is inhibited. So the HIF signaling is activated, and this HIF signaling activates all these transcription factors to lead to erythropoietin productions and the stimulations of the bone marrow for our red blood cells. So essentially, that's what they do. He has two main effects. The first effect is that of the stimulations of the productions of the erythropoietin, and the second effect also affects the movements of all these receptors and the porters, the ferroprotein in the gut to allow the release and the absorptions of the iron into the body. So when in very nutshell kind of way, when we talk about treating anemia in CKD, there is actually essentially two main methods that we are doing. The first is definitely iron, because it controls that rate limiting steps in terms of the maturation of the red blood cells. And of course, we always have the erythrocyte stimulating agents that helps to replace that loss in the erythropoietin during the CKD stage. The HIF inhibitors is up and coming agents, but it is yet to have gained a very strong foothold, but it will be coming out later on. So when we use erythrocyte stimulating agents to achieve higher hemoglobin level, there is actually many RCT that was done, especially in the early 2000s, and they uses various kind of ESA like the erythropoietin, alpha, beta, and even the darbepoietin. So all these are done over the years, and they all look at pretty similar things in terms of composite outcome. But however, if you look at the end results, some of them either stop early because of the excess adverse effect, like the mortality issues, the vascular access, thrombosis issue, or it just shows that there is actually no difference in terms of the cardiovascular event and what has worsened hypertension control and headaches, or they have worse endpoints like higher composite endpoints or the death, myocardial infarctions, and hospitalization for heart failure and stroke. So all in all, what it's telling us is that this ESA, using ESA, and especially at a high dose of ESA, to try to normalize hemoglobin to the normal range in a CKD population is actually not recommended. So which is why when KDO come away in 2012, the recommendation is already to be more calibrated in terms of the response. And they only suggest that we should consider only initiating ESA when it's less than 10, the hemoglobin level, and not exceed the hemoglobin level to more than 11.5 using the ESA. And that is the reason why in the earlier slides, when you look at the cutoff, even though some of them use a 12, we also look at less than 10 as a cutoff. So then what is the problem when you are giving patient ESA in a CKD patient, yet they are not responding or their anemia is not getting any better? So there is always multiple causes that can potentially cause it, from the easily correctable to the potentially correctable and the impossible to correct. And right up at the top of the list of the easily correctable one, you can see that is the absolute iron deficiency. So iron deficiency is a problem in our CKD patient because of absorption issues and the utilization issue. So, correction of iron deficiency in CKD population can reduce the severity of anemia. It also is an important cause of why patients are not responsive to ESA treatment. And when we decide on the type of the route of administration of iron, we need to firstly decide whether how severe it is, because the severe one, we tend to prefer using the intravenous way to quickly replace it. And of course, that is provided the patient has a accessible venous access. And also, what is the prior response when they were on iron, and what are the side effects they had when they had iron or intravenous iron, and whether the patient is compliant, especially with the oral iron, and the cost. And the absorption rate usually in a CKD population for iron is actually very low. Even if you put in like one tablet, they only probably absorb only 10% of whatever elemental iron they have. So when we also look at the interpretation of the iron study, we use transferrin saturations and ferritin concurrently to look at them. And the reason why we do so is that ferritin in our CKD populations can be falsely elevated because of these inflammatory states of things, and it tends to mask the iron deficiency. So what study has found is that when the ferritin is more than 300, almost all of the CKD population has a normal iron stores. But anything less than that is actually can be less. So definitely when we talk about absolute iron deficiency, where it means that there's severely reduced or absent storage iron, we're looking at a transferrin saturation of less than or equals to 20% and the serum ferritin of less than 100. However, there is also another entity we have to consider, which is the functional iron deficiency. They are patients with actually adequate iron stores, but they can't be released, to the marrow to be incorporated into the actual precursors. And this group of patients tends to have anemia, even with a T-set of less than or equals to 20, but very elevated ferritin level of more than 100, sometimes even up to like 500s. So that's why when we talk about these guidelines in terms of what is the recommended level to initiate iron therapy, we have the KDIGO, which is the international, the HIDOKI, the US guideline, then the subsequent is the Canadian, then the European, and then last one is the UK guideline. So these are the guidelines, but I think all in all, what it's telling us is that we can always consider in CKD patients with anemia, if you want to increase the hemoglobin level and the ferritin is less than 500, transferrin saturation is less than 30%, we can definitely consider initiating iron. And this is more or less similar to the US guideline, while the other guidelines tends to have a slightly lower threshold. So if you talk about the kind of iron formulas I have in my institutions and what my renal colleagues and myself usually use, we use that of the oral and the IVs. So the orals are the Sangobion's and the iron polymaltose tablets. In general, we don't recommend more than 200 milligrams of elemental iron per day in adults with iron deficiency anemia, and so that will be almost equivalent to almost about 2 tablets of iron polymaltose tablets. Otherwise, we use the intravenous. So what we usually use is either the iron sucrose or the ferric carboxymaltose. So there are a couple of studies that does talk about what is the effect of this iron use. So this is a very early study, a very small one also, and very short one, but it tells us 2 important things. So this is a study that looks at anemic hemodialysis patients with more than adequate ESA dosing, but with a transferrin saturation of less than 25, yet with a very high-ish kind of ferritin level. And when they gave these patients IV intravenous iron versus those and not given iron, And they want to look at the change in the hemoglobin within 6 weeks and the change in the dosing within 12 weeks. And it quite clearly shows that by just giving iron, you can actually improve the hemoglobin faster and a higher level. And you actually eventually drive down the dose of the erythropoietin. Then we talk about the later study, and this is a much major study, and it looks at an even more comprehensive outcome. So this is the pivotal studies in 2019. It looks at hemodialysis patients with transferrin saturations of less than 30%, the ferritin of less than 400, and it's already on the ESA. They divide them into two groups. The intervention group is the proactive group, which is giving high dose intravenous iron sucrose 400 mg per monthly, unless the transfer saturation is already more than 40% or the ferritin is more than 700. And the reactive group is patients that are only given iron as needed when the transferrin saturation is less than 20% or the ferritin is less than 200. And each group has more than 1,000 patients. And they look at the outcome, composite outcome of non-fatal myocardial infarctions, non-fatal strokes, hospitalization of heart failure, and death of any cost. So if you look at this, there is 15% risk reductions when you do the more the proactive group compared to the reactive group. And when you look at comparing the iron that is given in average, the proactive group receive about 264 milligrams per month, while the reactive group receive only about 145. And you can also see that there's a significant reductions in the need for ESA in the proactive group while maintaining the hemoglobin at a similar level. And in terms of any serious adverse effect, is actually comparable between two groups. And one of them is actually the infection rate, which was a concern for patients receiving IV iron. And that is actually comparable between both groups too. There's also a secondary endpoint, a pre-specific one that they look at the myocardial infarction rate, and this was reported in 2021 from the pivotal studies. And in the proactive group, compared to the reactive group, there is a risk reductions of almost 30% in terms of fatal and non-fatal MI. So this all shows that iron is definitely a good help in our CKD populations to reduce all the adverse outcome. However, IV iron has its own complications, but the serious adverse event that has happened has passed us some time back, because the one that has been causing us more problem was the olden use of the high molecular weight iron dextran, which is almost no one use it anymore. So subsequently, the serious adverse event is pretty rare. So there is some potential infusion reactions like hypotension, nausea, abdominal pain, fever. There's also maybe some localized reactions, especially if the plug is not set properly. There, I just seen a patient of mine with this hyperpigmented skin post-infusion, but it's all pretty self-limiting and rare. And the anaphylactic reaction is almost not seen anymore after no one uses the iron dextran anymore. In terms of the cardiovascular disease and infection, the pivotal study already shows that it is less of a concern. And then the last one, of course, is the potential risk of iron overload and toxicity. While in terms of the oral iron, there is again the GI side effect that we have to deal with, and that's a result of resulting in patient not being compliant. So I just want to talk one slide about the iron overload issues. Actually, when they did the study and look at it, definitely there will patient will have iron stores, and then when they did MRI of the liver, and they will definitely store iron store. But does that translate into adverse outcome? That is still, the jury is still out there and it's still debatable. But when you talk about real iron overload, the ferritin range I'm talking about is actually more than 2,000. And but being cautious, we definitely don't want to even reach that level. So that's why various guidelines has come up with their cutoff. So actually, most guidelines says not more than 500. But with the NICE guideline and the Canadian go even up to 800 or 1,200 per se. And my preference is that if the patient is doing well, even if the ferritin touch a bit above 500, I'm not going to stop it. I'm probably just going to maintain that dose. But if you keep going outrange and trending towards 800, I'm definitely going to be a bit cautious and start cutting down or even suspend the iron. So in summary, iron deficiency is one of the key contributors to anemia in CKD, and the use of iron helped us decrease the dose of ESA, which we have been shown to have causes more adverse effect. And the use of the IV iron preparation can be considered and should be considered in patients with very severe iron deficiency or those that are really not responding to iron orally. And the newer iron formulation has fewer anaphylactic reactions compared to the iron dextrans. And even with that, we do still monitor the potential adverse effect when administrating the iron. Thank you.
Thank you. Thank you so much, Dr. Craig, for the excellent presentation. Please, if possible, stay with us until the end because there will be a panel discussion later on. So I'm going to pass to Dr. Tay to introduce the next two speakers. Please, Dr. Tay. Thank you.
Thank you, Ronald, and thanks, Jia. So you've heard about the importance of iron in the heart and also in the kidneys. And now we're very privileged to have Mr. Richard Chan. He's a staff nurse at National University Hospital to share with us some tips and tricks. And this is probably one of the most interesting part because a lot of nurses know about the good things about iron, but now we're going to drill down to the real way of administering this safely for patients. So Richard, please.
Hi, everyone. Can everyone hear me?
Yes.
Okay.
Yes, we can.
Just give me a minute. Okay, hi everyone. I'm Richard and I'm from the NUH Outpatient Infusion Center, short for OPIC. And we've been established since 2009 and I'm a staff nurse over there. So today I'm going to talk about the IV ferric carboxymaltose that we infuse. Short form, the brand name is called Ferinject. So therapeutic indications, patients are sent to us when they are diagnosed with severe iron deficiency levels. And then IV Ferinject is prescribed for patients if oral iron preparations are ineffective or cannot be used. So the common dosages we infuse at OPIC is 500 milligrams, which is 10 mils, which is 1 vial. Our maximum we infuse is 20 mils, which is 1000 milligrams, 2 vials. And we do not administer more than 1000 milligrams more than once a week. But majority of our patients, after infusing a maximum of 1000 milligrams, they will not come back to us for the next 5 or 6 months or so. So we do patient assessments prior to the infusion. So we have to make sure that the patient is febrile, that their vital signs are stable, and make sure that they don't have any history of hypersensitivity to parenteral iron. And also we have to make sure whether is the patient pregnant or breastfeeding, because the IV infusion could affect the unborn fetus in a negative way. So in order to prepare the infusion, we will dilute 1 vial, 500 milligrams, to 100 mils of normal saline. And then we will infuse it over 15 minutes at 350 mils per hour via an infusion pump. So in terms of patient monitoring during the infusion, we will check the patient's vital signs every 15 minutes during and after the infusion. So after an infusion, the patient will be monitored for 1 hour to see whether there are any adverse effects. And at the end of the infusion, we would educate the patient where in the event of side effects, common side effects where they develop like a headache, we will advise the patient to take 2 tablets of paracetamol over the counter, which is over the counter, they call it Panadol. or develop mild urticaria, we advise them to see a GP for it. Or if they experience more serious symptoms such as chest pain or shortness of breath or severe urticaria, we advise them to immediately go to the nearest A&E. So every month we see about 20 patients for IV pharyngeal. And less than 5% of our patients get symptoms such as mild urticaria. So when that happens, we will stop the infusion immediately and give them 180 milligrams of fexofenadine, which is Telfast. It's an oral tablet. And usually after that, we will inform the doctor, and usually their symptoms will subside, and then we'll monitor them for about an hour, and if they're feeling well, then we will let them go home. So since 2009, we've had 2 serious cases where patients complained of abdominal pain. Then there was a case where patients had syncope for a few minutes. So during that time, the infusion was stopped immediately. And then after that, 500 mils of normal saline was administered at 1,000 mils per hour. And we also ran IV hydrocortisone, 100 milligrams slow bolus, as well as 25 milligrams of diphenhydramine and 50 mils of normal saline. So after that, after the syncope, the patient regained consciousness, and the patient was monitored for about 1 to 2 hours. And the doctor certified that they were well enough and they were discharged to home. Otherwise, that is all I have to share for the IV infusion of pharyngeal. Thank you.
Thank you very much, Richard. Please stay with us because I think there will be some questions coming in the end part of the session. So we'll move on to the next speaker. Next speaker is Professor Huang Yan-Chi. He's a senior consultant anesthetist, and he's the director of the cardiothoracic anesthesia program and also director of the postgraduate medicine institute in SGH. He's going to give us a talk on how to manage patients pre-operative before cardiac surgery with regards to iron deficiency. So, Prof. Huang, please. Prof. Huang,
Yeah, thank you. Yeah. Thank you, Dr. Ting. I just want a clarification. I've stepped down from my directorship for cardiac anesthesia and stepped down in directorship for postgraduate medical institute already. Nevertheless, thank you very much for the introduction. Today, hang on, let me adjust all this positions of the toolbars. Okay, today, thank you very much for inviting me to share from an anesthesiologist's point of view what is the current state of evidence and approach for iron replacement in preoperative cardiac surgeries. I will run through this few things: the prevalence of anemia in cardiac surgical patients, and the risk of anemia in cardiac surgical patients, and the risk associated with hemodilution during cardiopulmonary bypass, and the risk of red cell transfusion intraoperatively or postoperatively. Who are likely, what is the pattern recognition? Who are likely to receive red cell transfusion in cardiac surgery, clinical practice guidelines, and therapy for iron deficiency anemia, which actually has been expounded earlier. And IV iron for treatment of anemia before cardiac surgery is an ongoing trial. I just going to briefly describe what it is. ITEX is headed by Professor Paul Miles from Melbourne. It's a multi-center trial. Singapore is one of the centers. Okay, so the prevalence of anemia in cardiac surgical patients, okay, not just heart failure, but any patient coming for cardiac surgery, CABG, coronary artery bypass, mitral valve, anything. Up to 40% of cardiac surgical population, especially in elderly patients and those with comorbids and chronic diseases, have anemia. And like previously mentioned, they are also in the normocytic range type of anemia. Up to 10% of anemic patients have HB of less than 8 grams. And 50% of anemic patients have iron deficiency. let me get my slide next. Okay, so typically in the cardiac surgical patients, we also look after patients with chronic heart failure, either for valve replacement or transplant or LVAD. So these are just a sort of overview of how iron deficiency anemia can come about in chronic diseases. So either in the diet, or poor nutrition, or some bleeding. Patients with LVADs, they also have this other syndrome, which is similar to a von Willebrand's disease type. So they have little microbleeds. Patients who are on anticoagulant therapy prior to surgery, antiplatelet therapy, and of course, if there's renal dysfunction and chronic morbidity, chronic disease. Hepcidin has been explained by the renal physician much earlier about how hepcidin is an inflammatory protein which will be released and also present in inflammation as well as chronic illness, and it will block iron absorption and will block the transferring of iron from the stores to the marrow for meaningful production of red blood cells. So I wouldn't expand on that. Anemia in cardiac surgery, what is mortality like? For those with not anemic, the mortality rate after cardiac surgery is perhaps maybe 1.6%. This is already much decreased from a decade plus ago. Up to 4.7% of mortality if the patient was anemic pre-operatively. The top portion just shows that the logistic Euro score is similar between the two groups of patients. That means the entry point is similar, but if one person is anemic, then the risk of mortality is higher. So this is quite unique. If the patients come for cardiac surgery, there's one process that we need to stop the heart so that the surgeons can proceed to perform the surgery, the corrective surgery or the reparative surgery, or the heart transplant or valve replacement. The patient has to go on bypass, and to go on cardiopulmonary bypass means we take the blood out from the body and circulate around, and using a layman's term called a heart-lung machine, which will then provide the function of the heart and lungs, because during cardiopulmonary bypass, we bypass the patient's heart and lung function so that surgery can carry on. So this is typically calculated, the estimated hematocrit is typically calculated by the perfusionist who help us during that portion of time. So the preoperative hematocrit, which is approximately 3 times the hemoglobin, is an approximate value, 3 times. Estimated, multiplied by the estimated blood volume of the patient and divided by estimated blood volume plus a priming volume. The priming volume is the volume that's in the cardiopulmonary bypass circuit that has to connect, interface between the patient's blood and the system. Okay, so the cardiac surgeons will put the tube, cannulate the aorta, and cannulate either the RA or SVC or IVC, depending on the type of surgery. And that interface is crystalloid solution, and the interface is the blood on the patient side. Of course, if the estimated hematocrit is too low, then the perfusionist would have added blood into the cardiopulmonary prime, so the interface would become a blood prime. So that's to reduce bubbles. Okay. So now, if there is a dilution, because the cardiopulmonary bypass has this prime, which is crystalloid mainly, then we would have brought the hematocrit even lower. So lower hematocrit, we generally don't maintain, we will maintain hematocrit more than between 22 to 25%. That is a normal range of affair during cardiopulmonary bypass. There will be something like 7.5 to 8 plus grams during bypass. When patients get very hemodiluted, there is a lot of complications with physiology, neurocognitive impairment, stroke, myocardial infarction, renal failure, renal impairment, acute renal impairment, injury, and stuff like that. Although we can add blood to the prime, we call that extracorporeal, means outside the body, extracorporeal circuit to improve the oxygen delivery, but there are risks from renal failure as well as pneumonia. So it's a double whammy for the anemic patients. Being anemic, going on bypass, and staying anemic gets acute kidney injury, AKI. Topping up blood also results in some AKI. So whether this is the blood or the anemia, both ways the patient is put at risk of AKI post cardiac surgery. In fact, it's called cardiac surgery associated AKI. So what is the relationship of anemia plus transfusion? Pre-op anemia, if there's also intra-op anemia, plus the risk of blood transfusion, red cells transfusion, there's a high risk of increase in kidney injury. Okay, so what happens to these patients with acute kidney injury post cardiac surgery? A certain portion develops to chronic kidney disease. They begin to develop decreased renal function. About less than 1% eventually in about 4 or 5 years, this is our data and Singapore's data, develop end-stage renal disease. And the survival rate is at 5 years, 50%, at 7 years is about 38%. Okay, giving blood during bypass is also associated with wound infection. Infection was briefly mentioned just now, but specifically for cardiac surgery, the chest has to be opened in through the midline. We call it a sternotomy, and vessels have to be harvested from the leg or the arms or forearm for coronary artery bypass, for instance, so that we can harvest the veins and use that as a conduit. Conduit is just a graft in place of the patient's original artery. So you can see superficial wound infection would include the harvesting site, the legs and the arm. And the deep wound infection typically means deep sternal wound infection. So more than 4 packs of red blood cells, if we give, is associated with superficial wound infection. In a diabetic who receives also platelet transfusion, they also have a very high risk or increased risk of deep wound infection. So this just to show the sternal infection is worse if there's blood product requirement. And this is a systematic review. Now, in the anemic patients, this graph below, this diagram below, in the anemic patients, if they have a transfusion, if we give a transfusion, they are at a 2 times higher mortality. In the not anemic patients, but due to whatever reason, there's blood loss intraoperative or postoperatively, there's patient has been taken back for the surgeries for reanastomosis or hemostasis, and they receive blood transfusion, they are at a 3 times higher risk of mortality. So there's risk with blood transfusion. Of course, then there are ways to there are preventive strategies for minimizing hemodilution in a cardiac surgery during bypass. So there are many ways. Either preoperatively, we preempt such a problem and we work towards reducing hemodilution, or intraoperatively, what else can be done to minimize the impact of hemodilution. So now we do pattern recognition. Who is likely to receive blood during surgery? The advanced age, elderly, generally smaller body, generally lower HB, multiple comorbidities. So we can think about the chronic disease, ischemic and chronic disease. People who are already on coagulation or clotting abnormalities, or patients who are on antithrombotic drug therapy because, for example, arrhythmia, AF, they will be chronically taking anticoagulation or and people with coronary artery disease, or they're already taking antiplatelets therapy. And what about those with preoperative anemia? Can this be sorted out prior to surgery? The answer is very obvious, is yes. So one of these guidelines is, I use the 2011 guidelines from the STS, which is the surgical side, thoracic surgeons, and SCA, which is the cardiac anesthesiologist, and perfusionist group, and blood management group for cardiac surgery. They same like what was mentioned by Dr. Pok earlier. Assessment of anemia, determination of etiology is appropriate for all patients undergoing cardiac surgery, and it's definitely reasonable to treat intravenous iron preparation if time permits. So under the microscopy, iron or blood film, iron deficiency is usually microcytic, small. However, looking at a mean corpuscular volume and mean corpuscular hemoglobin concentration have found to be quite unreliable markers of iron deficiency status. And patients with both iron deficiency and anemia certainly have to be investigated a bit more thoroughly to exclude other pathologies such as occult blood loss, which is from the GIT typically. So routine iron studies for pre-op patients to determine the type of anemia so that the treatment can be instituted. And if the ability to treat is available without untowards effect, it should be started before surgery so that we can minimize the impact of hemodilution during surgery. And like previously mentioned, is the serum ferritin and the transferrin saturation is recommended, especially in patients with heart failure. And this is for patients going for LVAD or going for heart transplant, especially useful as a preoperative preparation of these patients. I just want to bring out this very interesting thing called the inaccuracies, what I call the inaccuracies of pre-op estimation of 30% hematocrit or 39 or so something like 13 grams. However, during acute stress, the spleen can be a storage, a sequestration site for a lot of the RBCs. And then, during stress, what happens is the spleen being the storage site will have a vasoconstriction and it will squeeze out more. So it looks like as if the hematocrit is high enough. That is in an acute stress state. So psychological stress states, people have done experiments with patients doing mathematics and doing mental work and see what was the hemo concentration like. And this is earlier paper from psychological stress. So we keep this in mind. If the hematocrit looks very good, and then just the first sample right after we anesthetize, and the first sample shows discrepancy, we can guess previously probably it was acute stress response or dehydration or hemoconcentration. Okay, so the formulation of iron has been expounded before, so I won't go into it again. And IV ferric carboxymaltose can be considered in symptomatic patients, has been mentioned already, so I wouldn't go through this. Oh, okay. So what happened is, the other one is also what was mentioned by Dr. Bernard Kwok before, the patients with heart failure, given IV iron, they have improved the 6-minute walk test, and they improve their quality of life. And what is recommended in a sort of internationally is that it be taken into account in the prehabilitation of patients for heart transplant. So in fact, it's to prepare them so that to reduce the heart failure hospitalization rates and then get them to tolerate and improve the physical capacity before this big stress called heart transplant. Okay, so recent papers, if there is preoperative iron deficiency anemia, oral iron can be given, but IV iron is recommended if time is short. We have heard many times oral iron therapy is poorly tolerated by many patients. IV iron preparations with different dosages are very effective even for 1 to 2 weeks, and earlier we heard was 4 weeks, up to 4 weeks also. Okay, so there's this recent study that they sort of a small study again, 24 patients with oral ferrous sulfate, and then they had 26 patients with intravenous ferric carboxymaltose. And they found that there was no difference between those patients who had both types of routes in terms of moving the median HB. However, the iron stores were improved. Okay, so this is common sense. The IV would have brought up very fast if the patients had chronic anemia. And they found that in the oral group, erythropoietin went higher, but in the IV iron group, interestingly, serum erythropoietin was noted to be decreased. So they have to sort this out. There's no difference in post-op. In this study, there's no difference in post-op blood transfusion, extubation, and time on the ICU and renal replacement. This just means that iron replacement is important. Whatever the route, given enough time, if you build up enough hemoglobin, there's minimize the risk of hemodilution during bypass, and therefore the cause is as expected. So why did the study produce this? It's most commonly the subgroup of anemia in cardiac surgery is most likely anemia of chronic disease or functional iron deficiency. Failure of IV iron to augment erythropoiesis in this group creates an uncertainty whether IV iron alone can overcome functional iron deficiency. All right, if hepcidin is very high, I think that movement of that store is a problem. Is there a need to sort of have therapy for more than 21 days, which is 3 weeks prior to surgery. So this is one of the questions left behind. Another study, also in the past 4 years, presented in Lancet, single center, what they used was patients received ferric carboxymaltose, subcutaneous erythropoietin, B12 iron, B12 vitamin, and oral folic acid. And they found that this ultra short treatment, the treatment was couple of days, a day before the surgery. That's right, a very short treatment. Sorry, I went back on a slide here. This ultra short term combination treatment with IV iron, subcutaneous erythropoietin, B12, oral folate, reduce overall RBC and total allogenic blood product transfusion. So in that way, we have this method seems like it would negate some of the complications post-operatively. Currently, there's this big trial going on, and this is just a midterm report by Paul Miles, I've mentioned earlier. It's a high-tech trial. It's to test the hypothesis that patients with anemia awaiting elective cardiac surgery will IV iron reduce complications and facilitate recovery. This is more important now. So 1,000 patients internationally randomized, including Singapore as well. We are donating patients. IV iron 1,000 milligrams within 6 months of elective surgery. Primary endpoint is number of days alive and at home after 90 days after surgery. So to date, this is a midterm report. To date, about 615 patients have been recruited. Mean ages about 60 over years old, majority male. Majority of surgery was CABG, with or without combined valve surgery. Hemoglobin on entry on the day of surgery is 11.8 grams, and 40% have evidence suggestive of iron deficiency. So that is it. They can't release more data because the results are not complete. We can't also release our data because we are bound by contract that even I don't get to see the results. All the results are channeled directly into the database. So we await this trial for the efficiency or the benefits of IV iron therapy in cardiac surgery in terms of outcome. So this again taken from 2021 SCS surgical field. They said in patients who have preoperative anemia refuse blood transfusion, this will be the religious group, and are deemed high risk for post-op anemia, then it is reasonable to administer pre-op erythropoietin stimulating agents and iron supplementation before cardiac operations. So this is like the desperate group that we can't give anything else. What else can we do? So they didn't include the IV iron inside, but certainly they said any sort of iron treatment should be also considered. So in conclusion, non-anemic patients will do well with surgery in cardiac surgery than anemic patients and be at less risk for transfusions with known risk for adverse effects. And the concept of patient blood management, which means perioperative conservation of blood, receiving blood, and conservation of blood loss, should be evidence-based, multimodal, multidisciplinary approach involving perfusionists, cardiologists, cardiac surgeons, anesthesiologists, and intensive care group. Not just conserving blood resources, but also to optimize outcomes in patients at high risk for transfusion. And the individual recommendations are to be incorporated as part of an all-inclusive protocol-based and shared decision-making approach, rather than just individual interventions to say, to reduce blood loss or transfusion. Thank you very much. So I've gone through the learning objectives briefly, the prevalence of anemia in cardiac surgical patients, the risk of blood transfusion, the risk of hemodilution, what's the pattern, who are likely to receive the blood, and some guidelines. And I didn't go in depth about the types of iron because it's been mentioned before. And I just briefly introduced that there's this ITEX trial in treatment of anemia in cardiac surgery that's ongoing now. Thank you very much. And this is thank you.
Thank you for the excellent talk and also
share.
So we're going to move on to the next session. We'll just invite all the speakers to come online, turn on the cameras. I'd also like to invite Dr. Lin Wei Chin. You didn't meet him earlier. He's a heart failure specialist at National University Hospital. And also have Dr. Raymond Wong. He's also the heart failure specialist at NUH. So we're going to move on to the discussion sessions. There's actually questions in the Q&A. So I'll get you to, I mean, you can put in more questions if you like into the Q&A box and try to get them answered. So let's start with Prof. Huang, since he's just finished his talk. Two questions for you, Prof. Huang. So the first one is, what is the reason behind, I know what the reason is behind after transfusion increased risk of wound infection or breakdown. You did mention that transfusion may be related or associated with this wound infection.
Yeah, so it's a hidden infective risk. That's more likely, and also actually why do the patients need blood transfusion is mainly because of bleeding and porous bones of the sternum. Those account for some of the reasons of post-op bleeding, and every transfusion has a risk of infection. This is not new, it's very old story already. Every 1 pint added increases the risk quite a lot. So I think it's just a hidden infective risk that is exposed, and also these patients are also in a stress form, their own cytokines are also coming up. So there's a lot of impact, not just infection causing, but there's also impact of the cytokine reaction. The other thing is also the wound healing. The wound healing at the edges of the sternum and the wound healing at the edge of the skin at the wound. Because the surgery is long, so they may be sort of decreasing in blood flow towards the edge. And also of course, in a bigger risk group will be the diabetic patients where their neutrophils are actually glycosylated, so their activity is not that active. So all adds to the wound infection. I hope that overall I summarize the answer for that.
Yes, there's another question from there's another question from Chun Peng. He's asking, what is the practice? Is it a routine practice for you to check iron panel for the bypass?
It is now like that. In the National Heart Center, I don't run that side of service. In the National Heart Center, it's quite routine now to study once they have anemia, they will study what's wrong with it. Even I see somebody's, I think his question also, in the other surgeries, do we do that? Yes, we do that. Heart center patients are screened at Heart Center. The other surgeries are screened at SGH, principally where I work at. And our pre-op evaluation clinic screens these very routinely. Anybody with anemia gets screened very thoroughly to find out, transferrin, ferritin, and all that, and then treated. And the patients also get the IV carboxymaltose prior to surgery. Thanks. I hope that answers that question as well.
Thank you. There's a question for Mr. Richard Chan as well. Richard, so this is somebody who asked about the symptoms of, you mentioned some of the serious symptoms like syncope, abdominal pain, rash. Are there other symptoms that you see typically with your IV iron infusion?
If you're talking about immediate symptoms, like the most common was just like urticaria, but otherwise, I have heard that some patients did go back home and they did experience like some headaches and muscle aches. Thus, we advise them to take paracetamol in that case. But otherwise, mild urticaria was the most common symptom we've seen.
Are things like chills, rigors, or nausea common?
No, I've never had that experience.
Yeah. And there's also another related question, more practical. If the patient has, say, an extravasation of the iron during infusion, is there any specific steps that you would take to address it? So extravasation of the IV pharyngeal. What would be the steps to take to address this?
Usually like I showed in the slides, we would immediately stop the iron infusion, and then we would immediately run like 500 mils of saline. Of course, inform the doctor right away to review the patient. Yeah, pretty much about the same steps as if we found a patient syncope.
Do they get phlebitis or kind of bad skin reaction if there's extravasation?
Not that I've noticed. Yeah. That's right.
Ronald, do you still see any more questions?
I do not see on my screen. Let's see. Yeah, I don't.
I just saw one. This is with regards maybe more specifically on interaction. So there's a question asking whether proton pump inhibitors can actually reduce iron absorption and lead to iron deficiency. And also related question, do we have to worry about brain iron deposition and increased dementia? So maybe one of perhaps maybe Bernard, do you know anything about PPIs and
yeah, I guess there has been some concern that the proton pump inhibitors may reduce iron absorption, leading to iron deficiency, amongst other things. So now I guess the discussion today is that when we document any iron deficiency, especially iron deficiency anemia, I guess the overall message today is that the intravenous replacement is the best route. So the use of PPI is not going to have any effect on that. And I guess the second part of the second question is whether there's going to be iron deposition in the brain. I don't know about that, but it's whether this fast infusion or rapid high doses of intravenous iron will lead to iron deposition, leading to conditions, a condition that's similar to hemochromatosis, which usually the iron will be deposited in the pancreas, liver, etc. Brain, I'm not so sure. Actually, we might have to check whether iron carboxymaltose or iron sucrose crosses the blood-brain barrier easily. I don't have the answer right now.
Maybe let me add on to what Dr. Kwok has said. So iron absorption in heart failure has been studied from the oral route, and oral iron absorption has been very, found to be very erratic. It's not only affected by PPIs, it can be affected by the food that you eat, and it can be affected by many other factors such as volume status. So that's why it's no surprise that a previous study looking at oral iron replacement, the iron out study, showed that there was absolutely no benefit between iron and placebo. And that is because of the poor absorption, erratic absorption. And that's why we generally now recommend IV iron. The effect of oral iron, not so much in the heart failure group.
Yeah, I think given that there's so much data in the heart failure with reduced ejection fraction, it's only natural that we have still colleagues who are interested in IV supplementation in the HFpEF group of patients. I think early on there was a typed answer, but maybe this is such an interesting question. So maybe Bernard, Raymond, or Wei-Jin can just give your thoughts about what you think. Is there a role for iron replacement in people with HFpEF?
Well, I answered it very briefly in 3 words, and that's I hope so. The difficulty is in recruiting enough HFpEF patients, defining accurately patients with heart failure with preserved ejection fraction, and then enrolling them into such a study. As it is, this group of patients, we have been quite stubborn in terms of showing any response or any benefit from the traditional medicines that we use for heart failure with reduced ejection fraction. So, but I guess the question is timely, and it is also about time that we start looking into, or someone start looking into using IV iron in HFpEF patients. Because if we believe the theory that iron deficiency leads to impaired metabolism of the myocyte, then there should be some form of improvement, if not in in clinical outcome, but at least in the patient's quality of life. Raymond, what do you think?
Yeah, wait, hold on. I can't get my video on. But anyway, yeah, I think so. I think quality of life is probably, I would say, is a given outcome that will be positive, but may not be anything more. So HFpEF is a systemic disease, so I doubt IVIG will make such a big difference. I will probably ask Wei Chin to comment as well, and maybe from that, I don't know whether I can extend the questions to Dr. Kwek. You know, the iron deficiency and anemia in CKD, how much does LVEF impact on what you would do or would not do? Maybe Wei Chin for the HFpEF prediction first. I cannot get my video on, sorry.
I think HFpEF is difficult. The definition of HFpEF, getting the right patient to recruit into a HFpEF trial is very, very tricky. But I do believe that iron deficiency is a comorbid condition, much like hypertension, much like diabetes, especially in the heart failure setting. So if you correct a comorbid condition, coexisting condition, patients are likely to feel better and have a better quality of life, similar to the reduced EF group. That's my personal belief.
Okay, so there's one more question about whether patients with a high-ish hemoglobin level of polycythemic patients will iron treatment increase whole blood viscosity. Maybe I can just chime in from the congenital heart perspective. I used to run a lot of these trials for patients with cyanotic heart disease, and they actually have very high hemoglobin levels. And we wanted to see whether giving them iron actually would make things worse. So, or make things better. So we actually put them through a baseline cardiopulmonary exercise test, and did that for all patients at baseline, and we gave them iron supplementation among those that are iron deficient, even though the hemoglobin levels were 16 to 18 grams. And we saw the increase in HB, but it never exceeded to a point where they became symptomatic, and there was a limit to which the HB would increase to, and all of them actually improved significantly on the CPET afterwards, suggesting that iron deficiency was limiting some of their exercise capacity. But this is only unique in this population, where this is a reactive, this is a kind of reactive hypoxia-driven polycythemia in this group of patients. But in patients with, say, rubra vera or a more kind of serious hematological disorder, I think you have to be more careful because this may run the risk of elevated HB, and of course, like you said.
I think in the AFFIRM AHF study, the HB cutoff was 15. Anyone more than 15, I think, disqualified and was not even offered ferritin checks. So in clinical practice, that's probably what we do as well. Anyone who has 13, 14 of HB, yes, we can still offer IV iron if they're iron deficient, but anything more than 15, we try not to.
Okay, so I'm probably going to just hand over the mic to Ronald. I think we have a fantastic discussion. So Ronald, maybe you can kind of give us your thoughts and your
Thank you really
summary.
so much for everyone spending a very nice afternoon with us, and also the participants. So we know that in the past 20 years, a lot of clinical trial data has accumulated, leading us to this seminar, and that we know that iron deficiency is prognostically important, and there has been more and more clinical trial and registry data suggesting that perhaps iron replacement is essential to improve outcomes in patients with heart failure, especially those with reduced ejection fraction and those who are undergoing cardiopulmonary surgery and chronic kidney disease as well. So while there are still a little bit of controversy regarding the exact target and how often we have to replace the iron, and certainly more work needs to be done in this particular area, but nonetheless, very rewarding, very informative webinar. Thank you so much for everyone's very excellent presentation and all the panelists' involvement in the discussion, and thank you once again for the participation and also importantly the support of the SCS and Singapore ACC chapter, and also the Swansea as well. Thank you. See you next time.